the brain met story, I think, is a nice story here in the ability to elicit meaningful responses in the brain with a therapy that's well tolerated. Is there a cutoff where you think, well, this patient needs to see radiation oncology rather than get a next generation TKI?
You mean before, instead of just relying on the TKI
Correct.
to try first?
Yeah. Is there a tipping point, Bob, where you think, well, you know what, there's a lot of edema, there's some neurological compromise.
We work really closely with our radiation oncologists on this question. In fact, Chad Rusthoven, one of our radiation oncologists, and I wrote an editorial on this. And I think for asymptomatic brain metastases, I'm perfectly fine, and so are the radiation oncologists, going with a brain penetrant TKI first, with follow-up monitoring to make sure that that the brain metastases are shrinking as expected. I think probably the cutoff for me is extremely symptomatic disease, although that could be controlled with steroids and other measures. I'm thinking there that we start steroids, maybe start the TKI, but also send them to the radiation oncologist. They can get that treated while they're on osimertinib, and that's not a concern, really.
So your comfort level is okay with using both the OC while they're getting radiation therapy?
I mean, it's slightly an artificial scenario, because if they're newly diagnosed with horribly symptomatic brain metastases, you don't have that molecular back, and they can't sit around and wait for 2 weeks. Right. So it's really the scenario where you happen to know that molecular information, and they land in your lap with symptoms.
But I've also had cases where a patient had locally advanced disease. I know their molecular profile because I'm doing the testing on those patients as well, and then they present with metastatic disease, including brain metastases. And what I've done is I've spoken with the neurosurgeon, spoken with the radiation oncologist. I say, look, is it pushing on something that's going to be dangerous? Like, do we have a little bit of wiggle room? And if they say yes, then I start the TKI and we go from there. And I've seen very nice responses when we've done that. I will say that when we give the TKI at the same time as the SRS, I believe there's a slightly increased risk for radionecrosis. It's not a substantial increase, but it's something we need to be aware of.
I don't think we have a lot of great data on that specifically with osimertinib, and it's always a worry with the more CNS penetrant drugs, but usually I think if you hold it, you just have to hold it right around the time of the radiation.
Yeah, the other message I think that's really critical is avoiding whole brain radiotherapy, right? So these are patients who often are going to live 3, 4, 5, 8 years, and really we want to avoid that. And so those are situations, even if the patient's symptomatic, even if they have 25 brain metastases, and we know that they have a CNS penetrant TKI option, I want to give that patient the drug, then re-image and see what we need to treat to kind of mop up that disease. But we've seen really significant toxicity, long-term cognitive toxicity in our patients who get that whole brain radiotherapy early, and I think we should be delaying that in every patient.
Absolutely, and I think even SRS, is not a complete kind of freebie. There is a risk of radiation necrosis, and again, for these patients who are living a long time, who may have multiple sites treated over time, that can also become a problem. So, I think that I agree, like you, we have a very close relationship with our radiation oncologist, and many of these patients I will have meet the radiation oncologist, and we'll follow them together so that we can make decisions based on the MRI. But I think, many of our radiation oncologists now know that these drugs are so CNS penetrant that they also feel very comfortable, forgoing radiation up front and monitoring closely.
I think it's a call for communication.
Absolutely.
Given the drugs that we have, and to make sure that that the players are all in the same playing field in terms of understanding how to optimize treatment strategies for these
Even
patients.
before the molecular testing comes back, if you have a patient that sees radiation oncology, calling them and saying, hey, let's wait for this testing to come back before we decide whether to give radiation, what kind of radiation, because there's a chance we may have something, better and less toxic to offer.
I think having a multidisciplinary team in this setting is so essential, and talking and making sure that you have a good relationship with your colleagues to make sure that you can talk about these topics. No one's trying to compete here, right? Everyone is trying to help the patient and make sure they get the best possible outcome. And I think that that's really essential.
I think it's important. I think we used to historically think of multidisciplinary teams for stage 3 patients, integrating the surgeon, the radiation oncologist. But with the advent of targeted therapies and the toxicities, even immunotherapy, the call for communication.
And local consolidative therapy, there's so many opportunities for collaboration.